Welcome everyone to this discussion section, and we are very happy to have Dr. Zhenke Wu with us today. Dr. Wu is an assistant professor of biostatistics from our department. He is also a research assistant professor at Michigan Institute of Data Sciences. Dr. Wu received his PhD from Johns Hopkins University, and his research interests focus on new statistical methods that inform the health decisions made by individuals. And his group actually has already developed a lot of original methods and software that are now used by many investigators from research institutes such as US CDC, Johns Hopkins, as well as the investigators from the developing countries like Kenya, South Africa, Gambia, Zambia, Thailand, and many other countries. So anyway, so Dr. Wu, as you can see, is a rising star in the field of precision healthcare and mobile health. So today we are very happy to have him to introduce and also discuss with us the micro-randomized trials in mobile health and also its potentials in the environmental health sciences. So today is our first time to have this virtual seminar. Feel free to raise your questions because this is discussion section, and probably it's hard to monitor the chat, so just feel free to raise your voice. Okay, so without further ado, let's welcome Dr. Wu.
Thank you very much, Lou. That's a very generous introduction. That summarized very well about my goal. Again, thanks for your invitation to join this discussion. So today, my goal is to use about 40 minutes tops to introduce conceptually what is micro-randomized trial and a few very quick examples in mobile health. So there are two goals for today. Let me see if I can switch to the next slide. There we go. So the first goal is to review micro-randomized trial, what it is for. So we will primarily provide a conceptual entry point to MRT. And for the sake of time, I will not cover data structure analysis techniques. So if you're interested, you can email me about relevant papers that talks about analytic techniques. So the goal today will be to sort of complete the introduction about why this MRT might be relevant for your research. And on that point, we will then have 10 or even more minutes to discuss how MRT designs could be potentially useful in environmental health studies with a sensor or mobile app component. So I'm very open to questions during the presentation, so do not hesitate to unmute yourself and ask questions, or you can type in the chat. I may not be able to monitor the chat, but whoever is moderating this, I believe Lou, you can interrupt me if the question seems to be a burning question. So let's just get it started. So mobile health, for people who are not familiar with this term, in general, it basically refers to the use of tools and platforms for health-related research and healthcare delivery. It is actually quite hot topic now, and based on my experience, when you're writing a grant to be submitted to NIH, if you have a mobile health component or mobile technology component, that usually makes the grant seems to be more exciting. And there's some reason for this, because the mobile devices has been quite ubiquitous, and the joke is that in many countries, people are more likely to have access to mobile phone than to clean water, bank account, electricity. And also, there are lots of improvements in recent years about how to design useful apps so that even research teams can hire their own analyst or software engineer and design an app that serves the purpose for their own studies. And this term has other names like telemedicine or telehealth or digital health or digital medicine. And actually, I think in last year or 1.5 years ago, the Nature has a partner journal called NPJ Digital Medicine. So this field is definitely gaining some traction. And there are not, the challenges are abound. For example, one biggest issue I had and was confirmed when I was starting to do mobile health related research is that many apps you download from App Store, some would say that, hey, give me 40 days, I'll give you, a perfect body or something like that. So these, or, you have like mindfulness apps, and those are in general targeted towards improving the mental health. So with good intentions, these apps, sometimes these apps do not based on solid science. And I think one thing I feel quite strongly is that in this field that involves mobile technology, there are so many innovations that are happening every year. It's very hard for the scientific community to catch up. So there are lots of validation studies that are required, and there are lots of statistical methods that needs to be developed to catch up with the innovation in technology itself. And other aspects, those are more tedious, but I just want to mention because we're talking about mobile health. So user retention is a huge issue. Most people, for many apps, people use them once or twice and stop using them or even delete them. And finally, if you do a study that involves a mobile app component, it's very important to have constant communication between the scientists in the team who knows the science to work closely with the developer of these apps. So there are lots of issues to tackle when you're trying to incorporate mobile technology component in your grant or project. But today, we're going to primarily focus on how do we use this mobile platform to deliver interventions. And our approach will be based on a particular statistical design called micro-randomized design. We will talk about what it looks like. We'll actually visualize what it looks like. But we will first talk about, its goal as is shown on the slide. And we will talk about adaptive intervention, and a more modern extension called JITAI, just-in-time adaptive intervention. And then we will talk about, what is the value of micro-randomization in helping developing just-in-time adaptive interventions. So, one-page summary of the value of MRT is essentially it generates data to help us develop interventions that are adaptive. When you're designing an app, it may include different components in the app, and you want to know which components works, which component doesn't. So once you know these information, you may be able to focus on a subset of the features and then to send them to a new cohort of people and to evaluate effects. I'll first start by just talking about the context in which MRT was considered. Actually, MRT, abbreviation for micro-randomized trial, has a very strong University of Michigan origin. Actually, it dates back to the time when, the SMART design, I believe that represents sequential multiple assignment adaptive trials. So MRT will be considered as some kind of intellectual child of the SMART designs. But all of these designs were trying to just be adaptive. So let's see what that means. In the figure, you see that we show 2 time points. Just consider month 1 and month 2. For this person, we're given treatment A and treatment A at 2 time points. But the same intervention may not work for all the people all times, because first you may have heterogeneity over time. What works at month 1 may not work at month 2. So you want to be adaptive in the sense of incorporating within person change. So that's the time aspect. And of course, there would be differences between people. For example, after month 1's assignment to treatment A, a subset of people may be responding to that treatment, hence it may be better to stick to that treatment. And for people who are not responding to that treatment, maybe we should change, we should switch to a new one, at least try it out. So adaptive interventions are trying to trying to incorporate the possibility of heterogeneity of treatment effects over time, and also treatment effects across people. And this is just a schematic representation of multiple, more than one time point. We will talk about more than 2 time points in the future, in the later slides. So what are the central motivations for adaptive interventions? So we just talked about 2 logically plausible reasons for considering interventions. In reality, it is actually quite needed, especially for many chronic conditions like mental health issues or behavior maintenance. So these are requiring, constant, reminder of, say, staying positive or having healthy behaviors. So interventions needs to take into account of the time dynamic aspect. And, we also need to take into account the heterogeneity between people. So broadly speaking, adaptive intervention is trying to achieve the best outcome for each individual. And it hopes to adapt to the needs, changing needs of each individual. Now, a more modern concept, just-in-time adaptive intervention. So the only difference is that we have a JIT now, just-in-time. It is basically a special case of adaptive intervention. The motivation for just-in-time is because when you have mobile device, and when these mobile devices have very good sensors, like GPS sensors, you'll be able to detect where this person is. So if your goal is to change behavior or to warn against risky behavior, like drinking or buying liquor. So when this phone is sensing that you're within 50 meters of a liquor store, it will warn you, say, hey, maybe it's good just to ride the urge out, talk to friends. So the hope is that this may cut the pathway between the urge and buying a drink in that particular at that particular time point, and hopefully can help prevent risky behavior like drinking. In other situations, these interventions could be provided as messages, like encouraging people to meditate, to practice mindfulness exercises. And the just-in-time is introduced basically to describe the much finer time scale compared to the classical adaptive interventions we saw earlier. So earlier it's like month 1, month 2, those are just placeholders. They are usually spanning much wider time periods. But for just-in-time, the time scale we're considering are usually like hours, minutes, days, if you will. And the reason why we can do this kind of adaptive intervention is indeed because of the improvement in the sensor technology and also the computational power of these mobile devices, so that we can sense in the context with much better accuracy, with much higher speed. So the interventions might be adaptive to those more refined timescales.
So Zhenke,
yeah.
So Priya actually has a question. So she asked, why is the study called micro-randomized? Is that because of sample size? And based on my understanding, I think like micro-randomized probably is because the time, like you have continuous time points to make a decision. But you can have a response to that question.
That answers the question. So micro essentially is to distinguish the classical setting where you cannot randomize very frequently. But now, because I haven't talked about it, but we will consider interventions that are delivered through mobile devices. And it's much easier to deliver push notifications, say, with much higher frequency. So that's the word micro. And we will look at that. We'll talk about that. And I think that's also part of the discussion. Yeah.
That's a very good question. And actually, as you were talking, and I feel like, oh, this idea can be used in a lot of settings. Like, for example, now we have the COVID-19, the pandemic, and then although you do not necessarily do the policy changing every minute, but you can actually more frequently to change your policy according to what is happening in this area during the past 7 days, for example, right?
Exactly. So these are the extreme examples to show what are the settings that micro-randomized trials or just-in-time adaptive interventions has been considered to be useful. I have worked on settings where it's 7 days as the finest time scale or daily as a finest time scale. So what you said is totally possible. It is at least at shorter time scales than classical trials where you can only randomize every month or every several months. So that's the kind of relatively more refined time scale. And I think this point of COVID-19 stuff is quite interesting because indeed there are so many apps that have popped out. You can download and they will just send you notifications about, hey, in your county, right, how many cases are there? I think if this is going to be a long-lasting pandemic, hopefully not, and we indeed have to make some behavioral change to keep ourselves and our families safe, maybe there is some place for a kind of adaptive push notifications to warn you against some risky behavior or risky kind of areas that you want to avoid. I don't know how to formulate this right now, but I think that might be of value. Yeah.
Yeah, totally with you.
That's right. Yeah, I saw Peter has a comment. Yeah, warning when 6 feet, apart. So next, I will just offer two very quick and brief examples where just-in-time adaptive interventions could be useful. Again, I'm not claiming that I have introduced the methods. I will not, but I'm just going to show you the examples, and I can provide references to these methods papers if you want. So both examples will be involved in some kind of behavioral intervention. And I know this is environmental health statistics discussion, and my hope is to somehow, connect the behavioral intervention aspect with the change in the exposure of individuals to some harmful, harmful exposures. So the first example, actually, it's like 6 years old, and it is about reducing the chance of people doing heavy drinking and smoking. So for 3 times per day, each individual will complete surveys. People call them ecological momentary assessment, or for short EMA. Basically, they will hopefully honestly answer questions about smoking urge, affect, and drinking behavior. They usually specify a window. I forgot exactly what's the time window here, but they will usually ask, have you drunk in the past, hour or several hours? And there is a very simple decision rule. If there is a high urge reported in that ecological momentary assessment EMA, the app will deliver an urge management intervention. So this is considered JITAI because it is relying on in-the-moment survey and using that information and according to a decision rule to deliver an intervention that may help preventing risky behavior. So this is an example actually that has been used by the first ever statistical methods that analyzes MRT data. So I'm happy to talk about that after this. But this is the kind of one of the oldest examples in JITAI. Second one, I'm not sure how many of you have heard about it. So this one is, I believe, either is still ongoing or just completed. So I got to have access to this data because a professor in statistics department, Susan Murphy, was here when I first joined the department, And she knew that I am interested in such kind of individualized health decision rules. And she was introducing me to this study. And I got to know the study PI and I learned a great deal. So I'm more familiar with this study. And the background of the study is that there are patients who are undergoing, who have finished their heart surgery. And usually it is advised that these people will, be in the training sessions, for like 7 days, and they basically will train how to walk and how to maintain a certain level of physical activity. But they have to be discharged, right, at some point. And these physicians worry that when these patients go back home, they will just stop exercising. And it is very common in post-operation, I don't know how to say that word, but after surgery, it's very common that exercise helps recovery. So the goal of this study is trying to design an app that's called Heart Steps to maintain the training that has happened in the hospital to, keep walking every day. And, in this app, there are 5, opportunities in the day that the user would specify, like, early morning, like morning commute, mid-morning, lunch break, afternoon tea, and evening commute, something like that. So at each of these time points, we have an opportunity to send out a message to encourage this person to move. For example, a message could say, hey, you have been sitting here for 2 hours. Why don't you stand up and walk out of the office and come back until you have found a squirrel, right? Those kind of messages. So those are like more refined interventions. And at the end of every day, the app will also pop out. It's also randomized. So some user on some days will not receive this intervention, but for those who receive this intervention, the user will be asked to plan an activity for the next day. And the idea is that by planning it, you have more motivation to move the next day. Okay, so the point number 2 and point number 3, these are like totally with good intentions, right? But we don't know whether it works or not, right? So at this moment, it's only about, hey, these are the interventions we're considering, but we need a design to assess whether these momentary interventions or daily intervention might work. So those are the questions that MRT would address. And with regard to the sensors, so there are lots of information being collected, including weather. Well, you have internet access by the phone or Wi-Fi access if you are at Starbucks. So you have the weather information in nearby locations, and you have your GPS location. And there are lots of complications with GPS location, but I will skip that for now for the sake of time. So that you know which neighborhood you're in, and of course, by having a phone, the app will know the walking information and other related activity information. And also the app will have access to the calendar or your calendar, so they know at what time you're busy in meeting, at what time you're idle. Okay, and again, the app will also send out surveys, like, for example, hey, can you tell me how stressful do you feel in a day from a scale of 1 to 5? So I'm listing only 2 questions. Another question may be, hey, how appropriate do you think those messages are, right? From 1 to 5. Maybe 5 representing you think those suggestions sent during the day are very helpful and appropriate. But there are other questions that were being asked of the subject every day. So as you can see, this study was designed with a good intention, trying to keep people moving. And it has different levels of interventions. Some are 5 times, at maximum 5 times per day, right? And it also has, at the end of the day, you have intervention that's more about planning, and you have passively collected information, which is very rich. And to be quite honest, as a statistician, if I can deal with each of these markers intelligently, I should be able to publish a lot of papers right out there. But the ultimate goal is to integrate all these information and to provide a more complete information about this individual's context and circumstance. And finally, we have these surveys. So these two examples, one with mobile basics to help reduce heavy drinking and smoking. The other, Heart Steps, is trying to maintain healthy behavior. They all have the common feature of trying to target moments where intervention might help. So now, after I have introduced the examples, I'd like just to summarize 5 components of JITAI. And these are relatively abstract, but according to my understanding, these summarize all the aspects you will need to consider when you are actually considering doing a JITAI study. Up to now, I haven't talked about MRT, right? I'm only talking about when you're designing stuff, designing interventions, what are the things you should consider? You may design intervention, but you may not know whether it works or not. And that's where the empirical evidence from MRT data would help. Okay, so I'll talk about these components first and move on to MRT. Decision points. Obviously, you have to provide a list of decision points where a message could be sent. For example, in the Heart Steps, before the study started, a user, for example, me, I have to say, okay, 8:30 a.m. you can send me a message. 10:30 a.m. you can send a message, and 1 p.m. you can send, and so on and so forth. And these sets of time points might be different between people, so as to allow different, lifestyles or working schedules. So these are the available decision points, and people may call them occasions, if you will. Second, intervention options. So people will just call them treatments in causal inference, but intervention options are just a more general term, and there may not only be one of them, there can be many of them. For example, the messages could be like 200 of them, right? You may be randomly choosing from 1 out of 200 messages. Of course, you have another option, which is not sending anything, right? And a most broad classification of these interventions that you will encounter in mobile health could be classified into pull interventions or push interventions. So if you are receiving a message, say, hey, you have been sitting there for a long time, it's because the sensors are sensed you did not move at all in the past, like say 2 hours. And that notification received is a push intervention because you did not need to go to the app to see this message. So usually, the second point, usually that's the one we're focusing on in MRT evaluation. But there are other kinds of interventions. You have to enter the app and see your own past activity or sleep information. So one thing I like to do, so I have a Garmin watch. This is Casio, it's a like $10 one, but I have another one which is much more expensive. It tracks all kinds of information. I always like to go back into the app and see how I was doing when I was hiking, my heart rate, and also if I was not sleeping well, I want to know how well, what happened during my sleep. So those require the user to enter the app and see the information. And some people would also consider designing very good components of these information so as to sort of engage users, so as to provide more useful insights for this person. And this person may be motivated to maintain healthy behavior or reduce risky behaviors. So those are the 2 broad categories, but most of the studies I'm involved in are dealing with push interventions. So
Zhenke, Priya also have a question about push.
Yeah. So the question is, so the pull is a doctor getting the message, and push is, so basically, if you're working, right, and ding, there's a message, that's a push, right? You do not need to actively open the app and enter it and see it. You can just see it on the screen, and it is sending you directly. And usually those messages were designed in the back end by some people who are predicting, hey, if this person is very sedentary now, what kind of message should we send? Should that message be very stern, or should that message be very soft, right? Those kind of messages. But for pull, usually that means, I'm really bored now. Let me go into the app and see the information. Oh, I feel really good. I walked 20,000 steps. Awesome. And there may be apps that doesn't have this component. So consider this component of offering information for the user, where the user can enter and see as an intervention. So this is what I mean by pull intervention. Correct. It's the app that's doing the pull or push. Pull is mostly participant initiated. Push is usually like, yeah, app initiated, or, you know, in the back end, scientist initiated. Okay. So 30 minutes now. So we talked about decision points, we talked about intervention options, and also there are tailoring variables. So I think for people who have worked on adaptive intervention, these are maybe quite boring to you, but I just want to mention them here. Tailoring variables are obviously, for example, if I was talking about helping people to keep moving, you have to sense whether this person was moving, right? So you have to use phones or whatever Fitbit to actually detect this person was sedentary in the past 2 hours. So that's passively collected information. And other information could include the time of day, the day of the week, and so on and so forth. And there are other types of information I do not need to say, but these are like survey information that user were prompt to answer, and these user answer them, and we know the context or the the mental state or whatever state of this person is. So these could be used to design what is the better intervention for this person at that right moment with these values of tailoring variables. And number 4, of course, decision rule, which you have to basically means that you map the existing set of information into an option that you would send to this person. So usually it's very hard to derive these decision rules, and Lou and other people have been working on this for a very long time, and I think now the challenge is how do we make this working for many time points, especially you have like 5 times per day, and if the study lasts for a year. And this is really the key for being adaptive. And again, this is a very naive example here. For example, if the sensor detects I am within 50 meters of a liquor store, and that happens because the GPS detects I am roughly here with some uncertainty bounds, and then there is a geotag location that says a liquor store. Either you tag that or other people tag that. And when your location, you're within 50 meters of that liquor store, it triggers a push notification intervention, right? So that's a rule. Otherwise, you do nothing. So that's deterministic rule there. Okay. And finally, you have to have the outcome, what outcome you care about. And this, I would say, is the most important thing I learned by doing this kind of work, is to distinguish distal outcome and proximal outcome. This question is usually also encountered in clinical trials, even if you just have one treatment. Because you have to consider, hey, what's the proper endpoint, right? Like the endpoint evaluate 3 months later or 1 year later. So those questions are still going to be relevant for this discussion. So the first one is about distal outcome. So the ultimate goal of we doing so many different interventions at very refined time points is to achieve a longer term behavior change. Like we want you to quit smoking. Yeah. And what just-in-time adaptive intervention is trying to do is targeting these proximal outcomes. By proximal, we mean those nearby future, okay? So for example, if the app detects I was sedentary in the past 2 hours, so the app sends a message to me, hey, Zhenke, start moving, right? And the proximal outcome would be my number of steps walked in the next 30 minutes, right? So, this may sound very trivial, but if this app is keep doing this for a very, very long time, the hope is that by encouraging these behaviors frequently, constantly over a long period of time, we would have changed the behavior for the better. So it's kind of, if you have a better habit, either formed by your own will or helped by a very helpful app, that will help you sort of to maintain a better behavior. Although I know it's hard, but that's the idea. And other examples could include the number of cigarettes smoked in the next 3 hours, the number of episodes of high smoking urge in the next 3 hours. So as you can see, these are relatively well-defined and more short-term proximal outcomes. And before I leave this slide, I want to say that in the field of psychology and in the field of, at least in like chronic disease management or drug abuse, what is the right time scale? Why 3 hours, not 2 hours? That's a very difficult question. I think it relies a lot on, the domain scientist. But I think, to be quite honest, not many people agree with a single number. So it's usually worthwhile to consider, the proximal outcomes at, a very large number of future time points, and offer these results to your to the collaborators, and hopefully they can draw some good conclusion there. But this time window is indeed quite hard to define. So you have to make a choice in a particular project. So 15 minutes left. Okay. All right. I think I have covered the most important point. We have 15 minutes. I do intend to use like 5 to 7 minutes to conclude this slide and leave some time for discussion. These are very simple slides, as you'll see. Basically, we have introduced the JITAI, which I hope I have convinced you there's a space for these just-in-time adaptive interventions to be useful. But how do we generate empirical evidence to say this intervention that my friend has designed works? If we are honest, right? So we have to generate data to either to disapprove the null hypothesis that this intervention does not work. So in classical trials, like I showed here on the left, you randomize at the baseline. You have, a person either have received treatment A and continues to receive treatment A, or in the other case, receiving B and continue to receive B. So sequential randomized trial could be helpful to deal with a situation where you may have dynamic contextual information, and you may hypothesize that the treatment effect might be different at different time points within the person. So the R represent randomization at the baseline. So you have the opportunity to get treatment A or B, and another time point. Remember, we call these decision points. We can randomize treatments to A or B, and same for the set of people who have received treatment B in the first time point. So here, for simplicity, I'm illustrating using 2 time points, but you can imagine that this can go further to the right if you have more time points, if you add more randomization. So this is usually called sequential randomized trial. This is not something new, but my point is that sequential randomized trials can provide you with very refined information about what treatment works at what time points. So this helps with the adaptive aspect. This slide is not different. I'm basically copying the previous slide figure here. And just to say that the re-randomization at month 2 allows us to figure out how to change the subsequent treatment based on data collected during the trial. And I would say that's the best thing I want to do, because I will be using the most data available to intelligently make a decision about what I want to treat for this particular person. And for long sequential version, I obviously cannot do this because I will only be able to use information. I have only one chance of randomization into A or B, so all the opportunity of assessing the intervention effect will be based on baseline information, or all the information before randomization. I only have like 2 or 3 slides left for MRT, and then will be discussion. So here it is a very schematic representation of what I talk about when I talk about MRT. So this is basically a zoomed in version of what happens within day T. We have 3 decision points in day T: morning, afternoon, evening. These are broadly defined. Individual may have different time points. At each time point in MRT, we are going to randomize people to receive message or not with, say, equal probability. And in the afternoon, we do the same randomization. And in the evening, we do the same randomization. So at these, if we do this for everybody, every person will have a sequence of treatments, and we will observe their outcomes near these decision points. For example, if we're talking about the number of steps walked after within 30 minutes of receiving the message, then we should be able to record those outcomes and consider them as responses. Yeah. And these MRTs are designed to assess the intervention effects at each of these time points. So I am being a little bit vague here because I haven't shown the math, but that's the very simple design here. Let me see how many slides I have left. Okay. So a few quick remarks about why MRT is useful. I always consider MRT in the context of JITAI. It is used to generate empirical data to evaluate whether intervention works at specific time points. And so it is particularly useful when the interventions can be delivered quickly and frequently, like text messages or notifications. And one thing I cannot emphasize enough is that the goal of MRT is primarily to estimate the short-term effect of these interventions and how those effects depends on time and context. So for those who are quick in thinking, then this basically means moderation, right? Interaction term between the treatment and other covariates that may moderate that treatment effect, yeah. And because of the, we need the interventions to be delivered quickly and frequently, and that is possible in mobile devices. And second, mobile devices have lots of sensors that can provide evaluation of, short-term outcomes. So that's why, MRT has been primarily used in mobile health space. In my experience, that the number of randomizations could indeed be hundreds of times. I haven't seen like thousands of times, but yeah, hundreds of times is quite common. Let me see how many I have. Okay, so I think this is the second to last slide. So again, we have data generated on MRT, and these MRT data will be used to evaluate whether these intervention options we have designed with our best intention, whether they work, right? Whether they have intended main effect, whether they have any moderation effect. In practice, usually these options are grouped into buckets, components, because you have like 5 team members, each of them say, hey, I think this may work. Hey, I think this may work. And the PI says, hey, let's combine them together, 5 components. Let's put them into the randomization so that each of your proposal may have a chance to be tested. So it turns out that maybe 3 out of 5 may be working. And then, that's, after you have analyzed data from MRT, then maybe in a future study, you want to focus on the 3 that actually may be proven to be having some effect, right? So you can further refine that. A second point, I believe it's probably too technical. And usually for a complete new study, usually these MRT data can provide some kind of best educated guess for what kind of decision rules you can use, in the subsequent reinforcement learning algorithm. But I will not talk about that, just to put it here. So to summarize, mobile technology has the potential to change behaviors and help sustain healthy lifestyles. We do so by using JITAI, just-in-time adaptive interventions. And we have talked about 5 key components. And the appealing feature is that it can continuously adapt to provide optimal support. And although with best intention, we may not know whether they work or not, so we need MRT to provide data to assess the effect of the interventions at any of these time points. Okay, so that's it for my presentation. I will have 3 discussion examples. Do you think it is meaningful to talk about the examples now, or I'm happy to answer questions first?
Hey, Zhenke, I think maybe we can answer a couple of questions. Because the seminar is scheduled until 50, and probably after that, some people need to leave.
Okay.
And one biggest question I think many people have, the confusion is actually, that for a 2-arm randomized trial, when people calculate sample size, it could be a large starting, or even with multiple arms, or maybe just a randomization and re-randomization, you need a very large sample size. So many people got the impression that with micro-randomization, you probably need a large or huge sample size. so then probably you can talk a little bit more about that. Maybe you have some assumptions to reduce the consideration, and then you still can have a reasonable trial to conduct. So Peter has one question related to that. I do have another question also related to this. For example, in the environmental health science, we have a lot of data that may have spatial correlation. The data may be correlated. So when you do have correlation, how do you handle those in your design? Yeah. So maybe you can go with the first question.
Yeah. So the first question is about usually how is the sample size calculation any different, or do we require large sample size? So I haven't written a paper on that. All I did was actually using the sample size calculator Susan Murphy's group has developed. So I can only speak to the fact that there is a sample size calculation formula. And the reason why that is doable is because we can estimate for a particular treatment effect you care about at a future time horizon, like at the next time point, what's the treatment effect of the current intervention? So indeed, they have a way to propose an estimator. They have a standard error formula there, so you can actually obtain the sample size by fixing power, or the other way around. I believe it is not closed form, so you indeed have to do simulation. But I can confirm a little bit later.
Right.
And regarding the yeah.
There is a little difference. Well, just my a little bit understanding of that is, they have some assumptions like Markov assumption. They are not considering the sequence of the treatment. For example, if I'm thinking about 3 time points and I have 2 treatments for each time point, then if I'm thinking the sequence, then you will have 2, 2, 3. That is 8 different treatment sequences. Yeah. And then if you want to compare these 8, sequences, then you're going to need a lot of samples, right? But then in their case, they actually based it at each time point, they will consider the different treatment. So that can reduce the needed sample size somehow, but they do need some assumptions like Markov assumptions.
Let me think. I need to check. I do not recall that particular specification, the Markov assumption, but sure. They have some independent assumptions. I can check.
Independent assumptions. Yeah, I mean, if you can follow up with a couple of papers on that, that would be great to send to the group. Right.
Yeah. Regarding the question of whether MRT is usually requiring large sample size, I have calculated this once for a study, and my experience is that it is usually reasonable. So because the question is rather non-specific, I can only sort of try to point you to the calculator, and you can sort of play with the parameters, and you can see whether those are, prohibitively large. So apologize, I cannot give you a more specific answer, but in my experience, usually, because individual provide, it's just like in longitudinal data analysis, right? And you have the benefit of having the person's past as the, reference. So you can usually sort of improve power a little bit. I cannot provide a more specific answer, except that indeed I see cases where not huge sample size would be needed to detect certain effect size. And of course, I have to be very clear, in the domain of mobile health, what is a good effect size? I think there's no consensus. So, for example, if you're reviewing grant and I say, hey, let's set the delta to be like, 0.1, is that reasonable? I don't think people would agree. So that's still an open question in terms of what's the effect size. So I do know that it's 50, so I can just stop and share the slides later, or I can continue talking.
I do have another question about spatial correlation.
Oh, spatial correlation, yes.
Yeah.
So that is something I'm actively working with Walter now. That's not a, we have figured out a simple, we have done simulation to show exactly, Lou, as you said, with correlation in some settings, the estimation cause effect may be biased. So we have broken the existing methods, and the question how to fix it. So we're still trying to do the fixing part.
Okay.
But you're quite right that I have been thinking about basically generalizing this kind of interventions to allow for the following features. First, just like, people may form groups, right? For example, we're in the biostat department, our outcomes may be related. For example, I was receiving a message, and I saw you in the hallway and I said, hey, Lou, let's take a walk, right? Our kind of physical activity outcomes may be correlated either because of latent confounders or because of our social interactions through interference of, so how to deal with that? I think I haven't figured that out, but that's important.
Yeah.
And second is what you said, spatial information that may cause correlatedness, right? For example, if you have a place where it's kind of cloudy and rainy, right? It's very hard to have people getting out of the house and move, right? And if it's sunny outside, it's easier. And so how do you sort of incorporating spatial information as a proxy to explain the similarity in the physical activities or whatever outcomes? That is, I definitely don't think that's done anywhere in literature. So if there's any interest in methods, I think that would be great contribution indeed.
Yeah, exactly. I think that would be an area that, environmental health science, like our research group, they can contribute because most of their data, they will have those. So like wearable device in the future may be very useful for the environmental health science as well. So then they should consider how to accommodate this special correlation into it. That would be great. So I think our time is up, and then you just feel free to go, but we will open the floor for the discussion. So we'll ask Zhenke to stay online. So just in case you have questions, just unmute yourself to raise the question.
So I saw a few questions. I saw R. Strauss. Can social determinants of health play a role in some of these correlation issues? Maybe, yeah. I think that I haven't done research using these information, but I think that may well be the case. Yeah. Thanks, Peter.
So Jamal, I have a question.
Yeah, thanks a lot, Dr. Wu. As you were presenting, this made me think about Apple's technology with their health app. And I was wondering how this would apply to what they're doing, because it seems as if this information that you're sharing basically means that we could export information for many users that already have the app activated in the recording, have like notifications sent to their phone for about their standing time, etc., and really use that information to see how effective it is at being healthier.
Right.
So I'm trying to understand like how what you found applies to what apps like what Apple has going on. Is it a way to understand the effectiveness of their apps?
I think that's the whole point of MRT. So imagine that you are now it's 1 p.m. It's actually nearly 1 p.m. and you receive the message, right? And the natural question is this message going to help you to improve the health outcome you're interested in? For example, the number of steps walked in the next 30 minutes, if the message is about, activity. So the way how this kind of design is doing is to pull together information from all the people who have received a message at roughly that time point, and all the people who did not receive a message at that time point, because these people receives or not receive message randomly, right? So you indeed have a chance to assess the causal effect of that message at that time point. But now you would say that at that time point, people are different. We're of different age, we're at different locations, and we were having different history of activities. That's exactly what we hope to answer is how, for example, can we sort of estimate the moderation effect of the message, sorry, moderation effect of these past information, like your location, upon the effect of message. For example, if you're in the office, maybe the effect of message is like very small because you have a lot of reason to not walk out of the office because you're expecting a call, for example. But if a person is at home or non-work locations, and you may be more relaxed, so receive a message, the same message, you may be more likely to move and produce walk more steps in the next 30 minutes. So these past information may well have a moderation effect on this message effect. So if I can do this for one time point, I can do this for any time point I want. The question is, how do we combine all these information together? Because sometimes people do not want to estimate one effect, one time point, they want to somehow pull them together. Yeah, so that's what MRT is trying to do conceptually. Yeah. I'm not sure whether that answers your question, but happy to talk more after this. Yeah, sounds like you're quite interested.
So another relevant question I will leave to you guys to discuss is, we mentioned about wearable device, but also there was a lot of sensors, like Peter mentioned about sensor about locations and a sensor about the air pollution, water quality. And once, you may have, how to measure those and in what kind of design, and then how those will affect your policy making. That will be very, noise is a good example as well. So those will be very helpful in a lot of our research topics.
Yeah, I think there are lots of things going on under the hood. I haven't reviewed all of them, including missing observations. How do we deal with them? So there are lots of complications. So I would say that definitely talk to an expert who has some experience in designing app or work on the data to give you some guidance if you're interested in pursuing this direction. But in general, I feel that this seems to be the direction where if you want to have frequent interventions, and hopefully all these small steps can contribute to longer term change, I think this may be a good direction to go.
Yeah. I see that in chat someone, Priya already have. I also have the class to go. I need to teach.
Okay, so, all right. I can share the slides if you want, but.
Yes, please. And Robin, should we close the section or you guys can stay on the Zoom for discussion?
We can keep it open for as long as anyone is interested in keeping it open. I do not have class, so I can stay as long as you like.
Okay, so Zhenke, you can decide when to close it, okay?
Sounds good.
Great, thank you so much. This is great. Yeah, very
Thank you,
interesting
Lou.
topic.
Thank you, Lou.
Bye, guys.
Bye-bye.
Yeah, sure, no problem. Thanks.
I can stay for 5 minutes longer and to see if there are any questions.
Great, yeah, thank you. Bye.
Hello.
So Zhenke, I am Songgyun.
Hey, how are you? Yeah.
You said you have 3 discussion examples. So do you have third one here?
I'm not sure whether that's relevant because I was trying hard to think about what is a potential environmental health one. I was thinking about heavy metal, and I was thinking about diet because if somebody eats a lot of fish, right, maybe that's some kind of risk. So I was thinking along this line. But I haven't done a lot of work in environmental health. All the work I've done was through Brahma. So he was doing those heavy metal and pregnancy kind of studies. But for MRT that have a component of proximal outcome that's kind of very frequently assessed, I need to think about it. So this is best I can come up with.
Yeah, I also throughout your talk, I was thinking, so maybe I better unmute my video as well. So I was thinking, so what could be potential example to use this design in environmental health study? And then like the more depression or some psychiatric
right.
change.
Right.
And so for me, it is very difficult to find how like this micro-randomized trial can change exposure itself. So it may be very difficult to change the exposure level, but given the exposure, so what would be health response? And then some factor, like an individual level factor, can modify the like a toxic level. And some of the potential example is this like a psychological stress
Right.
can modify the toxic chemical effect. So
Interesting.
if that is the true, then like this type of design can the control the level of
Right.
stress level, and
Yeah.
then so that's why potentially prevent any like a potentiated or synergistic chemical effect by
Right.
regulating like a stress level. So that could be one possible the example of
Exactly.
this design.
Yeah, the only hope is that the stress and the effect of the chemical actually has some kind of, as you said, potentiated or synergistic effect. That's true. Yeah.
Right. And like in, I don't know, so that just in terms of the change in exposure, like in, let's say in Asia, when sandy storm, during this early spring, the sandy, this particle coming from the Sahara, desert to the, China, Korea, Japan, and then some of the alerting system. But one of your the discussion point was the timing. So even though this is like a micro randomization, so that's why the time interval should be very short. But you have some example, you try like up to 7 days, so like a weekly,
Yes.
and so like an environmental level doesn't change as
Right.
quickly as something like other one. So that's why when we think about this environmental intervention, then the time interval could be somewhat longer than what typically this design is used. So
Yeah, I think, conceptually, as long as you have randomization at each time point you feel you can do something about, I personally would not be too worried about there are too long intervals. I think the only concern is that if I say have a notification, either through mobile phone or other things, hopefully it is generating some effect on some proximal outcomes. So I think we need to define those outcomes, and if they make sense, I would say this design will also help answer that question. I was definitely giving a very extreme example of minutes or hours, but in general, if you have randomization over many time points, this method would work. Yeah, the method will work. I think only in the applied sense, it can usually work. It also usually work for very refined time points.
yeah, but anyway, so this is very interesting design, especially for like if your goal is to change the behavior.
Correct. Yes.
Yeah. So yeah. So thank you for this interesting presentation and topic. Yeah.
Thanks for organizing. Thanks to Lou for inviting me.
Okay. So then, now very few people left right now. So if no additional question, then can we just close this presentation?
Sounds good.
Yep.
Okay.
Sounds good.
Thanks,
All right.
everybody.
Yeah. Thank you, everyone.
Okay.
Thanks.
Thank you.
Mhm.
Bye-bye.
All
Thank
right.
you.
Bye-bye.